Good
Good
morning,
morning.
evening, good afternoon, everyone. Thank you for joining us. This is Care Beyond Borders, Advancing Women's Health Through Artificial Intelligence. I am so delighted to kick off our latest LinkedIn Live series, both with a dear friend and colleague, but also on a topic that is both personally and professionally important to me. We have a great discussion for you all today, but we also want you to get involved. So please leave any questions that you have for us as we are chatting in the comments on the LinkedIn Live, and we'll try to get to as many of those as we can. For those who don't know me, I'm Rebecca Distler, and I'm the AI and Digital Health Strategist at the Patrick J. McGovern Foundation. We are a philanthropic institution focused on advancing AI and data science solutions for a thriving, equitable, and sustainable future for all. In our work, we bridge civil society and technical partners to help support human-centered technology and accelerate progress on global challenges. Health equity is one of those challenges, and it's something that's been the core focus of our institution since our early days. And when we talk about health equity, we can't do that without talking about gender equity. And I was reflecting, sort of about the state of women's health on a global scale. And when I was looking at some numbers in advance of this conversation, it's clear that in many ways our health systems today are failing women. According to the Global Women's Health Index, 1 in 3 women say that they've spent the previous day in physical pain. 1 in 4 say they have health problems that keep them from doing normal activities. And there's a whole host of data out there about billions of women who are not being tested for deadly diseases, who are not getting the care that they need. And this is before we even factor in socioeconomic status, race, factors we know further influence access, quality, and dignity of care. And yet there's so much potential to do more and to do better. We know the healthcare sector at large is navigating an exciting AI transformation. And with it, all sets of questions about how we protect patients, promote equity, ensure access, and then how do we ensure that these innovations and these potential benefits are extended to those that need them most. And so when I think about this intersection of digital and AI transformation and how do we improve the state of women's health, I couldn't truly think of a better person to be in conversation today than Dr. Neha Verma. Dr. Neha Verma is an entrepreneur. She's the co-founder and CEO of Intelehealth, a global telemedicine nonprofit focused on improving access to health where there is no doctor. She has a PhD in health science informatics from Johns Hopkins University, a BE in biomedical engineering, and her area of expertise, like I said, spot on for this conversation, Neha, digital health, telemedicine, public health, women's health, gender equity, all of which we're going to try to touch on in the short 45 minutes that we have with you. So Neha, thank you again for joining us in this discussion. Neha, I want to start with a little bit about you. I just I sort of previewed a little bit about your background, but tell us a little bit more about you, your interests, and what led you to IntelliHealth and the work you do today.
Thank you so much, Rebecca. I'm so glad that I was invited for this topic because it's so deeply personal for me. I started in telehealth because even as a woman of privilege, I faced some pretty major issues in accessing healthcare because of the persistent systemic challenges that exist for women. There was a point of time in my life when I did not have the autonomy to make healthcare decisions. And for me, digital health spaces like telemedicine, being able to call a physician when I needed, or be able to go to a health facility that was close to me, was a safe and accessible space. And I think that's why I care so much about this issue and why we started in telehealth, which connects patients with providers that are geographically far from them through virtual telemedicine connections. Uh, because this is health access is a major issue globally, but it's also a major gender equity issue. And we we're tackling that through telemedicine, which is a great solution to provide a equitable, gender transformative health care systematic systems approach. So really excited to be here and talk more about this topic.
Excellent. Thank you so much. And now I want to pick up on what you said, because I think that that question of autonomy and decision making is so important. And I love that you've brought it right to the forefront of this conversation. When we talk about telemedicine as a access and equity issue and both solution, can you tell us a little bit more about what that experience means for the women that you work with?
Mhm. Um, you know, in India, which is where I'm from, 90% of women cannot take independent decisions about their healthcare. They need input, permission from their parents, spouse, or in-laws. 50% of women are not allowed to go to a facility alone, and I used to be one of them. Uh, 17% struggle to find anyone to go with them. And as a result of this, almost 60% of women report trouble accessing healthcare services. It was when you mentioned that 1 in 3 women reported being in pain. I'm not surprised by that statistic, and thank you for sharing that one. It's because of these systematic challenges that exist for women. When you have a public health program for diabetes care, tuberculosis, malaria, reproductive health, um, the challenges is that even your public health programs that are not focused around solely around women's health, so not maybe the maternal child health or breast cervical cancer issues, even your public health programs that are focused on the entire population, the gains of them are not being received by women in an equitable way. And that's why telemedicine is so important. So when that woman comes to a community health worker and she has a high risk pregnancy or she has uncontrolled diabetes, uh, that community health worker is typically going to refer the woman. And most often, what's going to happen is because of that lack of autonomy, that woman is not going to comply with that referral. It's not going to go to that higher level health facility, is going to choose to live with an entirely preventable or treatable healthcare issue. But when you connect that community health worker at the point of care with a telemedicine connection to the provider at that next level facility, we've shown that you can eliminate up to 70% of referrals. And that means that women are then able to get care at that first point of care. So she can, and this is a health worker she can walk to. She doesn't need her mother in law to come with her. She doesn't need money from her husband to be able to travel to that next level facility. She doesn't have to arrange for childcare. She can get gender sensitive care where she needs it. And that's why telemedicine is so important.
No, I really appreciate that. And in many ways, what I'm hearing in your remarks is power, right, as a determinant of health. And thinking about the ways in which telemedicine, and I think by extension, as we'll talk about AI, can be an influence over that power. And I'm excited to dig into that further. Now, you teed up my next question really well, which is I wanted to, we have I think a quite broad audience with us. And when we talk about women's health, I do think so often, as you share, it typically focuses around a very particular time in women's life. Maybe it's sexual and reproductive health, maybe it is maternal health. And there is an incredible amount of both attention paid to it, and I think we can agree still entirely under resourced, under researched, and much more that we can invest in further. But talk to me a little bit more about how you think about women's health as in that continuum of care. And then I want to use that to kind of pivot into how we think about digital and AI innovations as supporting a broader continuum than perhaps we typically define women's health when we talk about public health.
Yeah, no, that's so important. I think so many of our resources, research, funding, focus, policy making goes around the period of fertility. Um, and that means issues like breast and cervical cancer, which are very critical for women, do not get as much attention. Uh, Issues like anemia do not get as much attention, or nutrition for women do not get as much attention. And then to add on to that, when you looking at women's health uh, from a lens of just these are the diseases that are specific to women, breast cancer, cervical cancer, is not enough. We also need to look at the diseases like diabetes, hypertension. Um, and one might ask, why do we have to look at it from a gender lens? I mean, diabetes is diabetes, irrespective of your gender. But the concern is that like 92% of women in India are not aware, have never, 98% of women have not undergone a screening for breast and cervical cancer. And only 27% of women who are diabetic in India know that they are diabetic, as opposed to men where the awareness of diabetes status and is a lot higher. So if you are working on a program or a health issue, it needs to be looked at from that gender lens. And I think AI has a really powerful tool to be able um, to make that and include and create more equitable systems, because it means we have to invest more. We have to invest more in that diabetes program if we want it to be more inclusive for women who have this condition.
Absolutely. And I think what I'm hearing in there, and Neha, if I can bring in some of the conversations you and I have had before, right, is it's both a how do we bring a gender lens to these kind of disease specific programmatic areas, but as what I'm also hearing, right, is how do we actually take a step back and think about how do we redesign systems, right, so that we're not necessarily going kind of disease by disease area, but we're taking a gender specific lens to that kind of continuity of care across the lifetime, whether that's, and I know we've had some good conversations around primary health care, for example. Would love to like bring some of our former conversations into this one for folks to hear and just touch a little bit more about
Mhm.
how you see that transition as such a critical part of this gender specific healthcare delivery.
No, it's primary healthcare is the first line of defense, right? It's uh, where we find and really focus on the needs of women and men and people of all genders, to and one of the persistent challenges is how do we improve screening for health issues that are currently going unaddressed, and how can we do that in low cost ways. And so AI has some really important applications there. There's some really amazing work going on in non-invasive anemia detection, breast and cervical cancer screening. Then there's, if you move on from screening to like diagnosis, the health system has a major problem of quality and
Yeah.
diagnostic quality, because we have so few providers and so many more patients than there are providers. And AI is a really great solution there to optimize your already overburdened workforce and expand their capacity so that you can take away tasks that really can be automated and taken away, like notes and summarization and information collection, but also diagnostic decision support and aspects of that, behavior change communication. So there's so many amazing areas in which AI can really help improve the healthcare system, and it will be a rising tide that lifts all boats. I'm
Yeah.
sure people of all genders will benefit from this kind of investment.
No, I love that. And again, a really great transition. I just want to name, I so appreciate uh, both your framing and taking the few minutes that we have to open this conversation with a grounding in the realities, and sort of the lived experience of what it means to go through these health systems and seek or have trouble with accessing care. But because I think so often when we talk about, and we are talking about it to our audience, I promise, but when we talk about the promise of AI, right, there's so much that's still promise and potential. And I think that being able to ground it in what are the actual challenges in terms of access, in terms of quality, as you just mentioned, that we are seeking to solve, that's going to lead to meaningful impact, I think is so important, both in this conversation and sort of in the broader AI and health conversation. I want to focus a little bit more then on the IntelliHealth telemedicine platform. You just named any number of really exciting AI use cases, right? From that note summarization to diagnostics. And as you said, those are areas that, particularly as we start to think about a broader conception of women's health, lift all boats, right? So often when we design for our most vulnerable populations, as we know in public health, you end up with better policies and programs and technologies that benefit sort of the broader populations. But let's zero in a little bit on the work you've done in telehealth, because this is a really exciting, very tangible use case. Would love to hear a little bit more about both that platform and how you're incorporating AI into your work to ensure that gender inclusive lens that you've laid out for us in your opening comments.
Yeah. Um, a lot of the work started also that we do in AI in telemedicine. One of the most common criticisms we hear about telemedicine is that there's barely enough doctors to do in-person care delivery. Now we want them to do virtual care as well. We can't add burden when they're, when without actually focusing on improving the efficiency of the healthcare system. So early on, one of the things we did within the IntelliHealth platform is we developed this digital assistant called IU. Uh, in the pre-LLM days, this was a rules-based digital assistant that guided a and we in at IntelliHealth we have two modes of teleconsultation. One is provider to provider consults where a patient comes to a nurse and the nurse connects them with a doctor, and there's also direct to patient consults where the patient can directly call a helpline or use an app um, to book a video call with a physician. No surprises there that the women prefer the nurse to doctor option because it's more accessible for them. They
Yeah.
don't, most of the time, they don't own their own phones
Yeah.
or have the educational literacy to do that. So when this patient comes to uh, the nurse uses the digital assistant to capture a detailed patient history and put it together as a really lovely summary note for the physician who can do before the consult. That helps in a couple of ways. The average consult time today, in-person consultation time today for healthcare services in the US is 20 minutes.
Wow.
For the average primary care consult in the US lasts 20 minutes. Uh, it's a little higher in European countries. And in India, it is 2.4 minutes. In countries like Bangladesh, it can be as low as 48 seconds.
Oh
That's
my God.
the average time of an in-person consult. And in that in-person consult, a World Bank study showed that providers are only able to capture 16 to 17% of essential information.
Wow.
How can we expect
Yeah.
our doctors to provide good quality medical care when they have a waiting room filled with 100 patients and only so much time and they have to get through all of those patients,
Absolutely.
right? So that problem is just going to remain in a teleconsultation environment. I now have a digital queue of 100 patients that I have to get through. But the healthcare worker can collect this information so that, and we have various research studies we've published on IU that shows that it captures up to 70% of essential history taking information that a physician would have captured. And what's also cool now is that we have this history note. It's captured, and the questions could be asked in the local language and then fed in using structured information, fire coded information, and all of that can go to a large language model or an AI engine to identify diagnostic disease patterns. So cough, persistent cough greater than so much time, also with fever that comes and goes. You can start to see, is this tuberculosis, is this fever? So you can create these clinical decision support engines that can be like a assistant to the physician as well. And what's also amazing in all of this is that we find that women are more likely to talk with their local nurse about sensitive issues around reproductive health, around that wouldn't have come up in that physician patient consult in the 2 minutes when there usually is a gender dynamic as well with the female patient and the typically male physician.
Neha, there are so many.
Yeah, that's
No,
a lot.
no, there are so much that I want to call out actually for our audience, just even in that example. The first is, as you shared, right, the innovation in like one of the innovations in telemedicine is that ability to meet people where they are. And when you were talking about sort of the difference in consult times, right? it is both a quality issue and a dignity issue, right? And being able to spend that time with that provider, to be able, and as you said, with that nurse, to build that connection, that's how we build trust in health systems, right? And I think so often, particularly when we talk about AI and data more broadly, we often talk about those who are missing from the data. And so often, I think we find that those who are missing from data are missing because of trust, right? Because they're not interacting with the health system, because they don't have that trust. They're not being seen as often. And so when we think about those existing data sets, that just like we see that bias trickle down even into the data. And so I just want to name that really powerful dynamic of being able to meet folks or meet women, particularly women, where they are, who they're comfortable speaking with. And then what I'm also hearing is, and again, to call out for our audience, there are two more things I want to call out, and then what you just shared. The first is being able to use AI not to replace that relationship, right, but to enhance it and amplify it and actually bring some of the humanity back into the interaction. And we would certainly welcome your kind of thoughts on, maybe perhaps let me welcome your thoughts on that particular point before I call out the other thing that I want you to share with our audience based on what you just said.
That word that you used, dignity, that is so important. I think overwhelmingly in all of the studies we have done, and we have surveyed like, thousands of patients on their experience of history taking using a digital assistant prior to the teleconsult. Uh, Overwhelmingly, the feedback is, I'm so happy, like the way that this nurse is now collecting my history, it's just like a doctor would. No one has listened to me so much. No one has spent this much time with me. And then there is that sense of, there is a reason why rural patients or low income patients or women today prefer to go to traditional medicine, unlicensed providers, faith healers, quacks. It's because they are listened to and they're provided with dignified care. It
Yeah.
may not be outcomes positive care, right? But it's certainly more dignified. And so one of the tenets for us at IntelliHealth is ethical, evidence-based, dignified healthcare
Oh, I
is
love
the
that.
guiding principle for everything that we do.
Wait, let's repeat that again for our audience. Technical, say that one.
Ethical, evidence-based, dignified healthcare.
Ethical, evidence-based, dignified healthcare. That is it's a little early in our conversation to have a powerful takeaway, but I really do love that one. I want to, we've got it, and I will name for our audience now. Please, if you do have questions, start adding those to the comments. We will try to open up some of that soon. But while I have the great privilege of continuing to be able to ask Neha some questions, Neha, you mentioned a little bit about this kind of transition into use of large language models, and I want to be able to focus a little bit on that because I think right now, and I imagine again we've got kind of a broad audience here. We have some folks that I think we've got some folks who I think are sort of more fluent in health, if you will. I think we've got some folks that are more fluent in tech, but certainly there's sort of a moment right now in which the health sector at large is grappling with this new technology, right? And what does it mean for our work? How can we best use it? I think there's lots of questions around challenges, around bias, around hallucination, right? Around what some of the concerns that we might have in using this in kind of sensitive environments, or and healthcare being one of them. Tell us a little bit more about your to the extent that I know this is a live project, so the extent that you can share, tell us a bit more about your journey into using LLMs and how your team has been approaching this new technology.
And absolutely. And Rebecca, I'm an informatician, which means I know a little bit about medicine, a little bit about public health, a little bit about technology, not enough to call myself an expert in any of these three domains, but being the jack of all that can bring those three domains together, which can sometimes be more powerful than being, one expert. And so apologies.
The audience would too.
Yeah. Apologies in advance to all of the physicians, public health professionals, and technologists listening out there. The work that we're doing right now involves taking the history notes that are created by IU, which is a rules-based digital assistant. feeding them to a large language model. And these are like really structured notes. So for the nurse, it's asking questions like, since when have you, if you have fever, since when have you had this fever? Or if it's an abdominal pain, what's the site of the abdominal pains? When did the symptoms start? How long have they been going on? So you're looking at site, onset, duration, all of those things that physicians ask. And all of that, the nurse is actually, to the nurse, the UI is in the local language. So the questions being asked in Hindi or Odia, and we also work in some countries outside of India, so it's in Kyrgyz or Russian or Arabic. And the answer choices are also in the similar language. And so the patient can pick, once the patient gives the response, the nurse can pick the right answer choice or free type in if none of the answer choices are applicable. And that free typing in could be in English or it could be in the local language.
Yep.
It depends on the provider. And all of this history note, which is a rich piece of information, which again, as I mentioned earlier, can capture up to, in some cases, 70% of all of the medical data that a physician needs to make a diagnosis. And it's provided right now. We're working with a few different LLM technologies. The ones we're seeing the most promise with is actually Chat GPT. GPT 4.0 Turbo is giving us the most accuracy. When we give this history note to the LLM with some very specific prompts, and what else goes into the prompt, not just the symptoms, but also the gender, the age, the past medical history, maybe past visit data, uh, even um, and data, contextual data around the location of the patient. Like if they are, for example, an LLM would even be able to parse out that this is a patient in an area where there is an outbreak of a particular disease. So being able to share all of that contextual information into the prompt, it then goes to the LLM and we receive a differential diagnosis, not a final diagnosis, but a rank ordered list of this is the likely diagnostic set, almost as a nudge to the physician for, with some like, don't miss these diagnoses, and a reminder, but also as a way for physicians to reduce their documentation burden. So they may pick option number 3 in the differential diagnosis list, but when they click it, they're saved the effort of having to type it in, put in the ICD code for it, or and also once they put it in, they can also get a prompt with these are the medication regimens, the standard medication regimens, and then they, again, with one click, all of those medications can be added in. So this is still obviously right now in beta testing mode. We're working on in one of our project sites. It's not obviously in routine patient care yet, but we're having some really interesting results from our pilot studies.
I love this, and I'll name something for our audience, and then I'm actually gonna bring in an audience question that I think really dovetails with what you're just sharing. Neha, I want to pick up on something that you shared for some folks in the audience, just to really, I think, drive home the importance of what you're sharing, right? Which is both the sort of clinical decision support aspect, and how do we it's almost like, how do we operationalize like this notion of precision public health, which I think we've talked about so often in the space, right? But this sort of gives you an ability to supercharge that and do it at scale, as you're seeing, right, in these telemedicine platforms. And then this very specific piece that you just mentioned, right, which is that it's serving multiple purposes, right? It's not just the clinical decision support, but the fact that it's saving that as structured data. And I think, when we talk about data, right, and the importance of data in training model, both in, I think, ensuring kind of continuity of care and improving and using that data to improve care delivery, but also when we think about how we might over time, let's say, de-identify and aggregate that data, right, to be able to train better, more appropriate models, that the ability to kind of structure that data feels like a really important output that perhaps we might overlook, but becomes part of the foundation for how we think about sort of future innovations in this space.
Yeah. And Rebecca, I also wanted to share with the audience some findings, because I feel like a lot of talk on AI is theoretical, and I want to be able to share our practical results. And we're really excited to be able to do that. We have a paper coming out soon about it. But one of the things we first thought of was, could we actually, because our history taking is rules based, could we actually turn that using an AI? Because rules are limited. And when a physician takes your history, based on your previous questions, they're going to ask different questions. They're going to be more optimal with their history taking than a rule. A rule will just want to go through a checklist of things. But as
Absolutely.
you've answered your first few questions, an intelligent person might already rule out asking a few more questions after. So we first started off by thinking, like, could we use GPT or Llama or MedPalm or any of these LLMs to actually, instead of using rules, use an LLM for decision data collection. And we did
Interesting.
not find very good LLM performance. LLMs were not really good with guiding someone through that history taking process.
Oh, that's so interesting.
And when we instead used rules for structured information capture, we reduced hallucinations in the clinical decision support section. So when we had LLMs go through history taking, the other challenge was repeatability. So for the
Yep.
exact same patient, the
Yep.
exact same case, sometimes the LLM would go down a different question pathway versus another question pathway, simply based on how someone may have used a particular word while
Yep.
answering something. So that was a very interesting finding for us. Another interesting finding was when you feed the LLM medical terminology, its accuracy of decision support is better. So, like if you said febrile instead of has fever, the differential diagnosis improved in quality as well as in confidence. So it was, and if you think about it, like if you think about why LLMs operate that way, it makes a lot of sense because they're trained on medical textbooks, and medical textbooks don't speak in layperson terminology. So that was another interesting finding. We looked at retrieval augmented generation to give context, and there was some very interesting findings on that. We did a lot on prompt engineering, and getting the prompt right is has so much impact on that LLM accuracy. So it's been, we haven't gotten to fine tuning yet because we found that there's a lot of gains that we could do simply from prompt engineering, RAG, and selecting the right LLM,
Absolutely.
training the data that you send to it, like the prompt, getting the prompt right. So it's been
Amazing. Neha, I cannot wait to read this paper. There's so many things that you've covered in there. And I want to name again a really interesting dynamic here with which what you're saying is with these new technologies, I think so often folks are trying to figure out where and how they start. And what you've just named, right? Prompt engineering, retrieval augment generation, RAG, and fine tuning is a bit of a continuum, right? Prompt engineering is easier than RAG, is easier than fine tuning. And so the fact that you're proving that there's a bit of a continuum here in which folks can actually engage with this technology and understand how to advance, their goals in their health programs, for example. I want to bring in two questions from the audience, and first is actually really specific to what we're talking about, which is, and I have to say we get this question a lot, right? You mentioned a bit of the repeatability. Right. So there's this repeatability challenge. And we know this is a challenge across generative AI because it's generative, right? It is kind of creating new answers. There's also sort of how do we know how it generated those answers? And so the question from the audience, right, is there, can this AI provide the resources to medical staff to show where it's pulling their assumptions from? Is that something that your team has experimented with or you've seen just in your work?
Yes. Oh, those are all such great questions, right? So, the there's a few things that you could do, like chain of thought prompting to elicit the reasoning for why an LLM came up with a particular decision. So, you can ask the LLM, tell me the answer for 4 plus 2, and it will give the answer 6. Or you could say, tell me the answer for 4 plus 2. And tell me what 4 plus 2 is. Here's a problem that I solved that shows 4. This is how we do 4 plus, like 4 plus 2 minus 1 equals what? And you say, and this is how I solved the problem. 4 plus 2 equals 6, minus 1 equals 5. That's how I got to the answer 5. So you give that as, this is how I would like you to share the answer with me. And so with that chain of thought prompting, LLMs can get to that. Have we succeeded at that? We're still experimenting, because I think that's one thing that physicians have consistently said would improve their trust in an LLM. If the LLM could explain why it put something at a differential diagnosis of number 1, as opposed to somewhere later, because maybe somewhere hidden in the medical record that the physician, maybe like 2 visits ago, there was this this rash that that patient showed up with that's relevant to why they're showing up today, and that's why that happened, right? And to expect a physician to have the cognitive burden of so much information is that's also undignified, honestly. To the sheer performance constraints, the performance expectations of physicians within the constraints we put on them is ridiculous. And this chain of thought prompting can help with that reasoning. And then I think you also mentioned a little bit about the fact that the like why that being the repeatability of the LLM is so important, right? The and better prompt engineering was resulting in fewer hallucinations and better repeatability for
Mm,
us. The more structured our history notes were going in, but also we realized we needed a test environment. How do we even say this is repeatable? And so what we did was we created a compendium of patient case studies, over 200 different patient case studies that are representative of the breadth of healthcare issues in rural India. So there's like case studies on tuberculosis and diabetes and women's health and urinary tract infections. So it's rare as well as common conditions.
yep.
And then for certain conditions, multiple case presentations because a certain sexually transmitted illness may not present the same way in all patients. And so when we had that reference standard, when we looked at that and compared the LLM performance to the reference standard, then you're able to actually measure, is this repeatable or not? Because if you don't have a gold standard, how do you know whether something is being is how do you know whether the output of something is good? So that's also an active area of inquiry for us. How do we even judge that this LLM's performance is good? What does good even mean? What is good enough for an
Yeah.
LLM to go out into a patient care? These are all so many fascinating questions.
Yes, and actually, you've again dovetailed right into the second audience question that I wanted to bring in, which is the repeatability, the benchmarks. These are, I think, what you're naming, right, are some of the challenges, and I want to extract this out a bit further, right, because I do think this is the question on everyone's mind, and again comes from one of our audience members about some of the biggest challenges that you see that impede the adoption of these AI powered tools. And I think what I might sort of add on top of that is I think you're naming some of the technical challenges as well. But let's take being able to both name sort of some of those technical challenges as you just did, and then to take a step back and sort of think broadly across the ecosystem. What are some of the other ones that our audience should be aware of?
Lack of reference standards to measure AI performance is a big uh, area of inquiry. Um, what is considered good enough? What's the threshold by which I say this LLM's performance is safe? Is it that it is equal to an in-person care provider? Does it have to be superior to it? Does it have to be perfect? Like that's your benchmark, really. Um, is it what does safe enough mean? And like looking at patient safety is so important in this space. You have to actively think of all the ways your technology tool may kill someone by missing a diagnosis, and there's unintended harm that could happen if your system is not accurately tested. So the next question is, what does that testing look like? How big does that sample size need to be to test? Especially when you're looking at diagnostic decision support, when you have a variety of health issues across a spectrum of care, what does that mean and what does that look like? There's also the challenges of working with data in multiple languages other than English. We still don't have good LLMs that work with local and Indic languages. There's the challenges of compute costs.
Yes.
So another interesting data point, when we looked at how many things that a theoretical clinical decision support system needs to make to say an off-the-shelf LLM like GPT, cost per API call, number of API calls needed, we would need about $360 per physician per year to support this AI assistant in just AI costs of an off-the-shelf solution.
Wow.
That's not cheap enough. that's still not cheap enough. That's not a price point that a nonprofit can pay, a government can pay. And so there's so many things that we need to do to bring those costs down. Open source LLMs, uh, more efficient prompting, and it's an active question of this. And then there's also all the data privacy issues
Yeah.
of LLMs that are off the shelf.
Yeah, absolutely. And I think it's interesting. This part of the conversation reminds me of a bit of an earlier part of our conversation, right, in which we were naming components and factors of health systems, and now in challenges of scaling AI solutions that solving those lift all boats, as you shared earlier in the conversation. Where the things that you mentioned are not specific to the use of AI in women's health, but in how we do this more broadly. And that in doing so, it's bringing that lens and saying, how do we do this well for the greatest number of people? That is so important. And in our last few minutes together, I want to bring us back to a little bit about this kind of focus on women's health. We had a participant earlier in the chat who was sharing a little bit more information about a webinar that they went to, and then the specific kind of case study that they had shared was that in heart health, for example, you have symptoms that are different between women and men, and we're sort of asking a question around how AI can manage the difference. And I want to, one, create space for you to comment on that, but two, let's use that as a jumping off point to say, knowing what we know about how AI can transform health systems, or is transforming health systems, as you shared, knowing what we know about some of the specific challenges to AI, where are those opportunities? One, sort of where and how do we think it is set up to kind of specifically address some of these kind of, let's say, more gender specific challenges, but also what are those opportunities that you're really excited about in terms of advancing women's health more broadly?
And it's such a fascinating area of inquiry about how health issues show up differently. There's the physiological aspect of it, but there's also the communication, like how women talk about certain health issues versus how others may talk about certain health issues. This is definitely not my area of expertise, as I'm not a physician, so I'd be able to comment about how symptoms may show up differently physiologically. Will AI be able to manage the difference? That's an interesting thing, and that goes back to AI bias, right? Your LLMs are trained on all kinds of medical information from the internet, most of which is research done in a certain population group, and it's not just like will AI be able to manage the difference? Not sure yet. Maybe there's things we can do like retrieval augmented generation or better context framing that can help the AI boost certain responses, because it's not just with the gender. There's a lot of diseases that are not studied in Asian populations or African populations. There's neglected tropical diseases. Will AI be able to identify that? Will AI be able to identify that? That goes back to just the core bias in the information that the AI receives to learn, and that's just a bigger, broader problem for the sector.
Yeah, absolutely. And as we wrap our time together, I know you've mentioned a couple of these use cases that you're excited about. Sort of perhaps like a quick rapid fire things that, like, when we talk about these let's expand out again. Let's go back to big picture. What are some of the innovations and areas that you're most excited about in terms of AI and women's health?
Image-based better diagnostics, so non-invasive anemia detection from photographs of nails and sclera of eyes, and better non-invasive detection of breast cancer using thermal imaging, better minimally invasive detection of cervical cancer using. And then there's also all these amazing AI tools of microscopy, where you can take a breast tissue sample to automate biopsy results. There's a fascinating group out of Hopkins working on this as well to improve breast cancer diagnosis. Then there's all of the things around language AI. So how can we use history notes, patient summaries, data? There's all of that. Then there's also the voice and physiological symptoms like cough sounds and lung sounds and all of that. All of that fascinating stuff like cough sound detection, using cough sounds for detection of certain diseases. I don't know that that all of this will be successful. A lot of this might just be hype, and we will find that the evidence shows that there is no way to measure X from this, measure or screen for this disease in this way. But I think they're all very interesting areas of inquiry. And then I'm so fascinated by multimodal and multi-model AI. So not just one model, you actually have a complex of multiple models that can arrive at you with a diagnosis. From the image, sound, your your history alone. The reason we choose to focus on history and spoken and that is because that is the majority of how diagnostic decisions are made. The spoken story, the patient story, like it goes back to that medicine saying, "Listen to the patient. She is telling you the diagnosis." That's kind of where it goes back to. So that's an area that I personally am most excited about, and we at Intelehealth are most excited about. But there's also all of these amazing applications.
Excellent. Neha, I feel like that is such a powerful note for us to end on, the importance of listening to her and listening to the patient. And when we think about all of the innovations that you've just shared and all of the many kind of challenges that you've also shared on the way to get to those, right? How do we continue to ground any conversation around AI and health, but particularly around AI and how we think about women's health in that patient-centric approach, and how we listen to her and how we meet her where she is, or her family is, and continue to bring that humanity and dignity into the conversation. So Neha, thank you again for joining us. For all of you online, I encourage you to both follow Neha and her work at Intelehealth. As you heard here, they have some incredible research that's going to be coming out soon. I personally can't wait to read it, and we'll make sure to share it with our audiences. So thank you all, and looking forward to our next iteration in our LinkedIn Live series.
Thank you.
Thank you.